And now we can go for the second lectures about epithelial ovarian cancer. Dr. Olfa Jaidane, Tunisia, surgical oncologist at Saleh Aziza Center in Tunis. She will present the lectures of Dr. Hatem Bouzaiene, because he is not here, about what is the appropriate approach for the management of recurrent epithelial ovarian cancer.
Thank you very much. Dr. Bouzaiene really apologized for not being here, and I will try to pass on his conclusions if surgery is the appropriate approach for the management of recurrent ovarian cancer, and in my opinion, it is. So, we all know that despite surgery and chemotherapy, 80% of patients with advanced epithelial ovarian cancer will have recurrence. So it is important to identify patients most likely to benefit from secondary surgery. And how it is possible? By determining time from chemotherapy. Is the recurrence platinum sensitive or platinum resistant? And to use some predictive score like the AGO score and the I-model score. It all starts with the Desktop 1 study. It was a retrospective multicenter series aiming to identify the appropriate endpoint of surgery and to create a predictive score to selected patients. It was published in 2006. And only R0 surgery was beneficial with a median overall survival of 45 months. And in the multivariate analysis, only 3 factors were impacting the performance status, the residual disease after primary surgery, and sites. And when the AGO score was positive, complete resection was achieved in 79% of patients. Then came the Desktop 2. It was a prospective study for the validation of the Desktop 1 AGO score and describing the surgery for recurrent ovarian cancer and describing its morbidity. It has been published in 2011. And in this study, there were enrolled for 516 patients with 129 patients with a positive AGO score who underwent surgery, and complete resection was achieved in 76% of patients, which validated the AGO score. The complication rate was acceptable, and there were really a few perioperative mortality. Then came the Desktop 3 trial, which is a prospective phase 3 randomized controlled trial evaluating the impact of recurrent ovarian cancer surgery on overall survival and describing the acute and delayed morbidity of this surgery. It has been published in 2021. The eligible criteria were the first relapse, platinum-sensitive recurrent ovarian cancer, and positive AGO score. 407 patients were enrolled in this trial. Complete resection were achieved in 74% of patients without any mortality. And as you see there, cytoreductive surgery did better in overall survival and progression-free survival than no surgery. And overall survival and progression-free survival benefit is significantly high and exclusively seen in platinum-sensitive recurrent ovarian cancer with positive AGO score and R0 surgery. And even in the subgroup analysis, cytoreductive surgery did better in all the subgroup without mortality and with less adverse event. Let's pass now to the second trial, the Chinese one, the SOC-1, which is the multi-center randomized controlled phase 3 trial. Here they used the eye model score and PT scan to stage the patients. And let me do a short reminder of the eye model. It includes FIGO stage, residual disease after primary surgery, platinum-free survival, performance status, recurrence level of CA 125, and sites at recurrence. And an eye model score of 4.7 or lower predict or potentially complete resection. And this score allowed to recruit more patients in the SOC-1 trial. So they enrolled more than 315 patients, and the primary endpoints were PFS and OS. And the conclusion of the study were that secondary cytoreductive surgery was considered complete in 77% of the patients. 5% of the patients who underwent secondary cytoreductive surgery experienced grade 3-4 surgical morbidity. No patient had died, and assessment of quality of life did not show differences among both groups of patients. And as you see here, in the surgery group, there were better progression-free survival significantly than in the group of no surgery. And the conclusion is that secondary cytoreduction followed by CT was associated with significantly longer PFS in patients with platinum-sensitive relapsed ovarian cancer when this surgery is performed in specialized centers, and long-term survival outcomes are necessary for evaluating overall survival. So can we compare this study? Actually, they are not comparable because they selected patients according to different scores, and there is a crossover from observed group and to surgery, reaching in the SOC-1 more than 36% of patients. And these two studies haven't evaluated the place of the new molecular treatment like the IPARP and the anti-VEGF. But the main conclusion that we can do is that there is a real impact of primary cytoreductive surgery on overall survival. And in this very recent meta-analysis, including the 3 randomized controlled trial, as you can see, cytoreductive surgery do better than chemo alone. So in conclusion, secondary cytoreductive surgery consolidated by taxane and platinum adjuvant chemotherapy and targeted maintenance approach is the proposed treatment of platinum-sensitive recurrent ovarian cancer for selected patients. So this can be the new standard of care for patients with recurrent platinum-sensitive ovarian cancer, but only when it is performed in expert centers. And thank you.